Hello and welcome to my series of conversations with men and women as ideas, vision and philosophy help define our contemporary world. My guest today is the President of the Public Health Foundation of India, but he has for long run and managed an NGO that he initiated himself called Doordarshan. He's also India's leading cardiologist, a former head of the Department of Cardiology at the All India Institute of Medical Sciences, who really made his sort of reputation, his mark in the field of preventive cardiology. He's published more than 200 scientific papers in the most prestigious journals around the world. He's a recipient of the Padma Bhushan, and the Society for the Promotion of Good Health in the United Kingdom gave him the Queen Elizabeth Medal. I'm delighted to welcome Srinath Reddy. Dr. Reddy, you've had a long sort of distinguished career as a cardiologist, and like many people from AIMS, you could have sort of retired and moved on as this preeminent patron saint of cardiology in India, but you have spent much of your career simultaneously looking at the preventive, the public health dimensions of this. But give us a brief sense of what public health is, because to a sort of common perception, public health is made up of the private health, the individual health of a lot of people. And when does the platform in a sense become public health?
Well, public health really looks at the determinants of health at the population level, at the societal level, and tries to address those determinants so that the health of individuals can be protected and promoted. Just to give you an example, when a patient goes to a doctor in a clinic, then that interaction in a clinic or a hospital is clinical medicine, where individual ailments are diagnosed and treated. But what has brought that person to the clinic, whether the conditions that caused the disease in the first place could have been avoided, the person could have been detected early and prevented from developing the disease in its full form, whether the person could have been referred in quick time and got medical attention at various points of care before coming to the hospital.
There are obviously sort of two dimensions to it, to a layperson. One is the purely individual, which says that eat healthy food, don't smoke, and exercise a lot. And then there is a social dimension, that if I need to exercise, if I'm living in a cramped urban space, is there a place for me to exercise? There is the supply push of tobacco, which young minds find difficult to resist. So in that sense, the determinants of disease are vast. Personal, individual initiative that is possible, and social, public, economic policy that influences public health.
Absolutely. Far too long, clinical medicine has looked at the individual factors only, the biology, the beliefs and behaviors of an individual, and tried to address them. But then we now recognize that there are also perceptions, priorities and pathways that operate at the family and the community level. And even earlier than that, there are also issues of development at the national and global level, the distributional issues of equity, the whole issue of demand and supply of trade, all of which in turn influence the pathway of causation. And therefore, if you really talk about whether fruits and vegetables are available at affordable prices, whether tobacco is being marketed very aggressively, whether road conditions are safe for physical activity, all of these are essentially environmental conditions which are determining individual behaviors, which in turn influence the biology of the individual. Therefore, when you're talking about preventing disease, you're not only talking about measuring somebody's blood pressure, but you're talking about how much of salt is there in the processed food that is being marketed. So all of these factors would have to be taken into consideration in public health.
What prompted your sort of moving, I'm not sure I should say moving away from, let's say, adding the portfolio of public health to your training as a cardiologist?
One is, of course, the frustration that we see increasing number of people falling victim to heart diseases, and particularly at a young age in India. In recent years, in the last 2 decades, the rates at which young people in the age group of 35 to 60 have been falling victim to fatal heart attacks has rapidly increased. We tend to treat many of them, and quite a few of them do survive, or effectively we do manage to provide care. But The inundation of our hospitals with this large number of patients obviously requires investigation as to why they are developing disease and trying to prevent the disease. Hospitals can no longer become only clinical care centers. We ought to really extend the ambit of care and prevention to the wider community so that we can actually prevent most of these cases from occurring, or at least delaying the disease. I mean, if somebody gets a heart attack at the age of 84, it's not really such a sorry affair. On the other hand, if somebody drops dead at the age of 42, certainly it's a major tragedy for the family, and even in terms of development, the nation loses a very productive resource.
I'd be sort of begging a question if I didn't ask you, and I'm sure it's something that immediately sort of, our viewers find a distinguished cardiologist. So what's the cardiology 101? What are the three principal pieces of advice that you would give to keep the heart attack between 35 and 60 at bay?
Well,
are there some basic, quick principles?
Very simply put, eat healthy food, which means moderate salt, moderate intake of refined sugars, healthy fats in preference to unhealthy fats, plenty of fruit and vegetables. Combine it with good physical activity on a regular basis, 30 minutes minimum, 60 minutes preferable, 5 days a week or 7 days a week if possible. This need not be done at a stretch. It can be done in 2 or 3 accumulated periods, like 10 to 15 minutes twice or thrice a day, and stay away from tobacco in any form. These are the 3 principles.
You've been actively working in some arid areas, and certainly tobacco has been a very major thrust area. You have been recognized for your contribution to, by the WHO. And you talked about sort of the linkages of development of economic factors. Are you frustrated that we haven't seen the kind of, I don't know what, the way in the United States, for example, the tobacco farms have been hauled up and forced to pay compensation in a sense directed to the public health system and advocacy that has happened there, and we have really not significantly been able to make a dent on this, other than some areas of keeping tobacco advertising out of sport, some public advocacy, but it really hasn't become a movement.
That's true. Part of the problem is that India, at least in terms of the policy makers, have only recently made a shift to seeing tobacco as a public health priority rather than an economic gain. And this transition has happened only in the last 10 years. So governmental policies are really gearing up at the moment. And unless there is a fair amount of public education, the public also doesn't recognize the threat of tobacco as an immediate and dangerous threat. In the United States, of course, part of the problem has been because the amount of evidence that was available, both from industry records as well as large-scale epidemiological studies done in the US, could persuade the courts and the juries to award large-scale damages. Unfortunately, even our scientific research has lagged behind in documenting similar studies within India. But I think even that particular gap is being covered now, and the issue of liability and compensation could come up in India as well. But even while waiting for the courts to consider these issues, I think what is clearly needed is a twin approach. One is a top-down regulatory approach, proactively curbing tobacco in many of its dimensions, in terms of its marketing, in terms of its advertising, ban on smoking in public places, plus a bottom-up community mobilization approach, which really makes people aware of their entitlements, tells them why they need to keep tobacco out of their homes and out of the streets and out of their lives.
You're watching a conversation with Professor Dr. Srinath Reddy, a former head of cardiology at the All India Institute of Medical Sciences, the president of the Public Health Foundation of India. We'll be right back after a short break. Don't go away. Welcome back to continuing conversation with Professor Dr. Srinath Reddy. We were talking about tobacco and how in some ways there was the need not to wait for the courts to get into action. But in terms of the everyday experience of people in India, we don't even have access to basic medical clinical health services, and we see this huge mushrooming of private sector medicine. What role do you see for the public sector, for social spending on clinical medicine, because while intellectually the community still sees the larger role for public health, and certainly when it comes to infectious diseases, and as you've sort of written extensively, there has been a shift at looking at public health not just beyond infectious and communicable diseases to some of the other issues we're talking about. What future do you see for our ability as a community, as a society, to access quality clinical medicine? Because that's the most immediate, urgent experience that we have of medicine.
Sure. I do not think we can really do away with a strong public sector involvement in health. Health is a situation where the market forces do not operate very well, because it is a provider-driven market. There is an asymmetry of information between the so-called provider and the consumer, which makes the doctor and the hospital the main determining force as to what treatment is required, what investigations are required. So if you leave it entirely to the private sector, there is an element of exploitation that often occurs. And secondly, we must recognize that even diseases such as heart attacks and diabetes are now becoming far more common among the poor and the less educated as these epidemics develop. So they cannot afford expensive angioplasties and surgeries in private hospitals. They need care in public sector hospitals. And the public sector therefore has to remain very strong and responsive to the needs of the people. And even as the private sector grows to play an important role, it needs to become responsible in the sense that it has to actually follow ethical practices, ensure that its costs are not very high, that they remain affordable, and therefore a responsive public sector and a responsible private sector would together contribute to a healthy framework of health services in India.
As a public health activist, do you have the faith, and this has to do with sort of economic models of development, that it is possible for a private sector hospital, when you've, invested that many crores in an MRI machine and you need to recover your investment and all the sort of other things that we hear about, is there a reasonable possibility that might happen? Do you still have faith in in the principles of capitalist competition that will deliver on this?
No, I believe apart from an ethical code that every healthcare provider, private or public, must adhere to, it is also important for a regulatory framework to prevent abuse. In many of the countries abroad, you do have regulatory framework which is not only imposed by professional organizations through guidelines, but also by monitoring agencies and even insurance companies whose corporate interests are threatened if there are excess healthcare charges. Now, we ought to ensure that in India, where there is a laissez-faire atmosphere and very little regulation or monitoring, that these mechanisms are brought into place. I do not expect the private sector to act entirely out of an altruistic motive, but at least there should be a minimum conduct of ethical behavior that they must adhere to, or they should get the rap.
You have, in your work at the Public Health Foundation, advocated the significance of having that many more, substantially increasing the number of public health professionals to further the agendas of. What is the work? What are some of the key mission statements or mission ideas of the Public Health Foundation?
One of the major problems is that even if the government and other societal forces have been investing a fair amount of funds in national health programs, the delivery has been very poor. And that's partly because of lack of public health professional expertise in the health systems. You find otherwise competent orthopedic surgeon or an ophthalmologist sitting as a district health officer, having to supervise vaccination programs and child nutrition programs and population stabilization programs. His acquired skill sets and assigned functions are badly mismatched. And we therefore require to bring in people with a knowledge of public health, epidemiology, demography, social sciences, management skills, who can actually manage some of these programs much better while leaving the clinicians to do their job which they're good at. And it is this deficit in our health system that is actually impeding efficient implementation of our health programs. That's why we need to flood the system with public health professionals at different levels with different sets of competencies. I mean, even at the block level, you don't need a doctor. A good multipurpose health worker or a nurse or even a BSc in public health, which is a course we intend to create, could actually perform several functions. But at the same time, at the level of the secretariat, you need a policy person who actually understands public health before they start deciding how much money goes to which program.
You know, a determinant in the new economic models is often cost benefit. I mean, you know, we really stop looking at human beings as human beings, and we say, well, you know, 100 crores of investment in this is going to lead to so many savings in terms of man hours lost. It tends to be an economic argument. In the Indian context, I mean, outrageous though this feels at the human level, at the national level, is there any data that suggests that, look, if we put in so much money in public health issues, this is what we're going to get out of it? That's question one. And an allied question is what I circumscribe with. I feel a sense of outrage. Now, that may be sort of naive, that we should be looking at health issues in terms of numbers, but is that inescapable?
Well, as long as economists are the ones deciding the policy, whether in the planning commission or in the government or any other agency for that matter, we need to take these economic indicators into consideration. When you do cost effectiveness analysis or cost benefit analysis, one of the benefits is that you can choose between programs and try and choose which is the more efficient option, where each rupee can actually get better buy.
So you have finite resources,
yeah,
and
finite
where
resources,
best you can
yes,
apply it.
where you can actually apply it best. But that's not the only consideration. Equity is an important consideration. So when you're really taking decisions about health, you're looking at two aspects. One is the economic component of what is much more economically efficient or cost effective. Second is the human rights component of who need it most. And we ought to balance both of these. You cannot blindly go into an economic alley. You ought to balance it with equity considerations as well.
You know, you have a background in Western medicine, and much of the discourse tends to be focused on the Western systems of medicine, and then the feeling sort of that alternative medicine is out there. It's somewhat sort of it's the flaky stuff because it doesn't stand up to the kind of scientific scrutiny that economists want, and government policy must pay some lip service to it. After all, it's less expensive. You don't have to worry so much about side effects, another sort of misconception about it. What is your understanding, the role, the place of alternative systems of medicine, which of course range from the non-interventionist, non-invasive to you can do Ayurvedic surgery, you can do pranic healing, to homeopathy, to mainstream yoga. There's a whole gamut of this.
Well, I believe there is a place for all systems of medicine, and each of those systems must be accorded their due respect. The way allopathic system is advanced has essentially been because of demonstrated scientific basis. That level of scientific evidence has not been gathered for other systems of medicine, though the evidence has been mostly experiential, anecdotal, and possibly still that evidence is worth considering. I believe a good deal of these alternate systems of medicine, especially Ayurveda and other systems of medicine, emphasize the preventive aspect and the promotive aspect of health. They are not always looking at individual ailments in a very reductionist fashion and trying to treat the specific organ or tissue. They are looking at individuals, and also they are placing the individuals in their environment and trying to correct the imbalances both within the individual as well as the imbalance that exists between the individual and the environment. So I think there is a tremendous amount of wisdom that is to be learned from these systems and applied. And we in allopathic medicine, when we are talking about good nutrition, good physical activity, we are recognizing that we are actually repeating what has been really enunciated in the other systems of medicine. While these could be very complementary, I would not even say alternate, but they could be very complementary systems of medicine, it is also necessary for us to try and test out these systems of medicine through appropriate scientific methods.
Sense that Western medicine tends to describe or go into looking at mental health when a fairly extreme boundary has been crossed and it becomes a problem. But the point really is that if a person is content, if he's calm, if he's happy, is he less likely to get a heart disease, even if his cholesterol is high, and even if he meets the scientific measurable parameters? The government of Bhutan has gone into measuring the happiness index.
Yes.
Does the happiness index play a role in personal health?
It does. You see, when we are talking about stress, stress is a response to a physical or a mental threat or a perceived threat. And stress does act through various biological mechanisms. It has its effect on pulse rate, blood pressure, blood clotting, adrenaline is released, steroids are released, they increase the clotting tendency. So what we are measuring in allopathic medicine are the signals that emerge from a stressful situation.
I'm talking about unhappiness.
Okay, unhappiness.
Is that the same as being
Sure.
stressed?
It's been shown that unhappiness, grief, all of this set the stage for heart attacks. All of these have been well associated. The so-called psychosocial factors have also been identified. So we will not downplay them. And just because it is difficult to measure some of these indices with the same level of precision or pseudo precision that we can measure cholesterol or blood pressure doesn't mean that we can dismiss them. I think we ought to really take all of these into account, and a true doctor is one, true physician is one who actually can take that holistic perspective. Some of these are deficient in our training, and I suppose even in our training systems in allopathic medicine, we ought to really bring back some of these elements of our traditional medicine and infuse that into the wisdom that is conferred by allopathic medicine.
Even as we record this, you're counting down to a major international initiative, a conference, a meeting that looks at bringing and involving the youth in the kind of agendas that you are pursuing. And again, while idealistically it seems that the youth represent the best point of intervention, they are the nation's future, but there is also the perception that the youth really don't have the time to think about health. They haven't really been hit by it yet.
Well, if you talk to a young person that, look, you might get a heart attack or you might get a cancer 20 years down the road, they will not bother about it. On the other hand, if you discuss with them the conditions that are creating illness, instability, ill health all over the world, and then also get them to recognize that policies which are short-sighted today will have tremendous adverse impact on their future in the 15 to 20 years down the road, not only on their personal lives, on their family lives, but on the whole conditions of society, then they start examining these issues seriously, because they don't want to fall victims of other people's follies. And for example, if you look at the environment, the Nicholas Stern report talks about the way the environment is actually being degraded, and talks about how 20% of the world economy is going to be lost in the 21st century because of global warming. And it's the same environmental degradation that produces conditions of ill health all over. Or if you talk about flawed agricultural policies, in India, an average Indian has about 130 grams of fruit and vegetables per day. The World Health Organization says you require 500 grams of fruit and vegetables per day. So where is the production, processing, pricing mechanism that makes these available?
Notwithstanding the fact that we have a predominantly vegetarian diet.
Yes, exactly. So given these factors, the young people must recognize whether it is how tobacco is marketed, or how safe are our roads, and whether road traffic accidents are claiming lives at a young age. What are the social conditions and what are the policies that are generating illness, endangering health, and contrary-wise, what are the policies that can actually promote and protect health? And if they become conscious of that, they can become very active votaries of a policy change, of a social transformation. And they take ownership of the programs. They don't like to be prescribed to or preached. On the other hand, if you actually give them the ownership, they are willing to become agents of social change. And that is exactly what we are trying to do here. Not only give them information on the basis of which they can make personal choices, but also give them the basis for informed health advocacy through which they can ask for better policies which can alter social conditions in a manner favorable to their current and future health. And they're actually trying to improve the whole of society, not just their own individual health.
You've been extensively concerned about other issues such as diabetes and obesity, and that is an emerging global agenda. But very often when you're talking about issues of young people, these are related to sort of lifestyle issues. The consumption of aerated drinks. It's not just about pesticides, which has been in the news recently, but about how that leads to obesity. And certainly in the United States and in several other countries, you have schools and institutions have been discouraged or have banned keeping things that are unhealthy. And yet you have a huge economy, you have a huge, large commercial interests that are driving the consumption of obviously unhealthy things without the same drama as, say, tobacco.
Yes.
How do you begin to combat this?
The food industry is actually a very strong agent of these kind of changes that are occurring in society because of the commercial marketing. Just as tobacco is an advertised addiction, obesity is a marketed malady. And we must recognize that, and we must counter that again. In fact, in the United Kingdom, they have now asked for, as a governmental measure, that the food industry must cease advertising to young people of high energy junk foods. European Union is now advertising a similar imposing a similar code of conduct. In Denmark as well as in New York now they've asked for not only the processed food industry but also the restaurants to remove trans fats from the entire food preparation process. So these are the kind of things we also ought to be looking at and taking preemptive measures before the epidemic peaks. We ought not to wait for things to get really bad before we start acting. We still have plenty of opportunity to use regulatory measures and policy instruments to control the epidemic before it actually reaches unmanageable proportions.
Dr. Reddy, you've sort of a distinguished continuing career as a cardiologist, working now in the areas of public health. You continue obviously to retain and work in cardiology. What do you see yourself wanting to have achieved? You're probably sort of somewhere near, I don't know what, 60, 70% of your professional career. What would you like to have seen achieved, eradicated, improved, and that you have made a significant contribution? What is that single driving passion at age 90 or 100, and may you live long, that you would like to have achieved?
Well, I mean, it's easy to say that I would like to see all conditions related to health in India in a perfect shape, whether it is health services or medical or other training institutions and
beyond
so on.
utopia.
But what I would really like to see is empowerment of the people. Empowerment of the people with health literacy, empowerment of the people with suitable social conditions for them to lead healthy lives. And I think it's people's empowerment that's absolutely critical, and we professionals are merely catalysts for that. We have to act as informed facilitators who can change policy, and we can help inform the people to mobilize themselves. And I would like to really see a galvanized India which believes that health is important both for its development and for its moral stature as a country that respects the right to health.
Thank you, Dr. Reddy. That's a great inspiration.
Thank you.
Thank you. Good luck.
Thank you.
Thank you. That was one.